Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Today we're going to be talking about benign liver masses. Hepatic cavernous hemangioma is the most common benign hepatic neoplasm. It's composed of disorganized endothelial cell-lined pockets of blood vessels supplied by a peripheral branch of the hepatic artery. Hemangioma is more common in females and uncommon in cirrhosis. When a known hemangioma is sequentially followed in a patient with early cirrhosis, the hemangioma involutes as the liver becomes more cirrhotic. Hemangioma may range in size from less than 1 centimeter to even more than 10 centimeters. Giant hemangiomas tend to have a non-enhancing central area representing cystic degeneration. On CT and MRI, a virtually pathognomonic imaging feature is peripheral discontinuous progressive nodular enhancement. Let me take it again. Peripheral discontinuous progressive nodular enhancement. The degree of enhancement should match the blood pool on all images and demonstrate gradual centripetal fill in on lateral faces. When we say centripetal, it means it is filling in from the periphery towards the center. Centripetal towards center. The non-contrast CT appearance is really not helpful, as hemangioma appears as a non-specific hypoattenuating liver mass. It could be anything. You can't clearly call it a hemangioma just on the non-contrast. On MRI, hemangiomas are typically T2 hyper-intense and become even more hyper-intense on T2 fat-saturated images compared to conventional T2 weighted images. So these images are depicting a hemangioma, and it's a study of dynamic contrast enhanced T1 MRI. We have the early arterial in the top left here, and all the way to the delayed, that's the bottom left image here. And this shows a segment 8 lesion pointed to by the arrow and demonstrates peripheral discontinuous nodular enhancement. As you can see, it's not the entire periphery that is enhancing. You have just a little bit of it enhancing here, nodular, and it's discontinuous, right? And there is also progressively increasing centripetal enhancement. So as you can see, it appears to be filling in towards the center, progressively towards the center. That's what we call the centripetal filling. And this goes all the way up to the delayed images where it's almost completely fills up. The signal intensity of the peripheral enhancement is similar to that of the aorta. So that lets us know that it's hepatic arterial, and the hemangioma appears hyper intense on the T2 weighted image that's here. The classic ultrasound appearance is a circumscribed homogeneously echogenic mass with no flow on color Doppler. Interestingly, no flow will be seen on color Doppler, even though it's blood vessels that are wrapped up in there. I'm guessing it's because the flow within them is very slow. It can't be registered by the ultrasound machine, so it appears to have no flow. Posterior acoustic enhancement may be present. A hypoechoic halo or a target sign really should never be seen. This finding suggests malignancy. Ultrasound appearance of a hemangioma can be confusing in a patient with underlying fatty liver and may appear relatively hypoechoic compared to the background liver, because the liver gets brighter when it's fatty on ultrasound. And so although a hemangioma is a hyperechoic lesion, the liver may be brighter than it, and so the hemangioma would appear darker in a fatty liver. So this ultrasound is showing us a cavernous hemangioma here through the right lobe of the liver and demonstrates a circumscribed, slightly heterogeneous echogenic mass with mild posterior acoustic enhancement. The CT that is shown here is in the portal venous face. It's an axial cut, and it demonstrates a hypoattenuating lesion with peripheral discontinuous nodular enhancement, typical of a hemangioma, as we discussed in the previous slide. If a solitary classic appearing hemangioma is seen on ultrasound and the patient has an otherwise normal appearing liver, normal liver function tests, no known malignancy or risk factors for hepatocellular carcinoma, and is asymptomatic, then no further workup is required. Any heterogeneity or atypical ultrasound findings should prompt consideration of an alternative diagnosis, such as hyperechoic hepatocellular carcinoma or metastatic disease, even in the absence of a halo. In a patient with cirrhosis or any known primary malignancy, further workup, that's MRI or CT, is usually warranted. Focal nodular hyperplasia is a hematoma consisting of disorganized liver tissue with no malignant potential. FNH is called a stealth lesion because it resembles the background liver parenchyma. Of course, it's just hyperplasia of the liver cells, right? That is focal nodular hyperplasia. And so it will resemble liver parenchyma on all modalities, except in the arterial phase imaging due to its vascular supply. Approximately 15% of FNH have a characteristic central scar consisting of biliary ductules and venules, which does not contain fibrotic tissue and therefore is not really a true scar, as opposed to the fibrolamellar HCC we remember in the previous presentation, which does have a fibrotic scar in the middle. So that will help us understand the imaging characteristics, especially the T2 imaging characteristics, differentiating FNH from fibrolamellar HCC. If you remember, we mentioned that fibrolamellar HCC would be the central scar is T2 dark on all sequences. However, the central scar in FNH is T2 bright because it's not really a scar. It's just biliary ductules and venules that are in there. Also, FNH does not have a capsule. MRI with EOVist contrast is the most useful imaging modality to diagnose FNH. FNH typically is iso-intense to the liver on all MRI sequences. Like I said, stealth, except it is arterially hyper-enhancing and will show retained EOVist enhancement. So you would see iso or hyper intensity relative to the liver parenchyma in the hepatobiliary phase. That's about 20 minutes after contrast administration, like really delayed, due to the presence of hepatocytes and biliary ductules. And you know, EOVist is a hepatobiliary contrast agent. It's taken up by the hepatobiliary cells. So it makes sense. The central scar will show delayed enhancement with extracellular contrast agents such as Gadavist, but will not enhance with EOVist. It's not enhancing with EOVist because it does not have hepatocytes in the central scar. The central scar does not have hepatocytes, and so it will not be picked up by EOVist. So these images show us a case of focal nodular hyperplasia, and the T1 weighted MRI shows a barely perceptible mass in the right liver, the right lobe of the liver here. It's barely perceptible. It could even be passed as normal, but the other imaging sequences would point it out and let us know retrospectively that there's actually a mass there. What we actually can't see is this low intensity scar pointed to by this red arrow here, this low intensity scar here. The T2 again shows an iso-intense mass, but this scar that was hypo-intense here is appearing hyper-intense on the T2 MRI. Arterial phase enhancement shows avid enhancement, and the central scar does not enhance. And this avid enhancement washed out in the portovenous phase with no change in intensity of the scar. So you can see the scar is still dark. On the delayed T1 weighted image, we see late enhancement of the scar. So now you can see the scar is now bright. All these are the characteristics of a focal nodular hyperplasia on MRI. It can be difficult to see on non-contrast or portal venous phase CT, as it typically matches the parenchymal attenuation, as I have been hammering over and over. On a multi-phase contrast enhanced CT, there will be bright and homogeneous arterial enhancement, with the exception of the central scar, similar to MRI. And the portal venous phase will often only show the unenhanced scar, which enhances late. Lasts about 5 minutes. So in this image, the liver exhibits a large iso to hypodense mass lesion with pronounced contrast enhancement in the arterial phase, and this is in the left lobe of the liver. It manifests a central scar, as you can see in all these phases, and this central scar kind of blends with the lesion in the delayed phase, telling us that the scar has enhanced to match the parenchyma. And all these findings again suggest focal nodular hyperplasia. Ultrasound findings are non-specific. The central scar is rarely seen on ultrasound, and even when it is, this finding can be seen in other lesions, including hepatocellular carcinoma, giant hemangioma, or an adenoma. Doppler findings of FNH include a spoke wheel configuration of arterial vessels. See the spoke wheel of a bicycle radiating like that? Yeah. So that's how the vessels appear on Doppler imaging. So this Doppler ultrasound shows a liver segment 7, segment 6, hyperechoic mass here. Let me draw the outline here with central vasculature. So all this is the liver vasculature, but within this lesion, it has its central vasculature that appears to radiate from the hypoechoic center here. So we have a hypoechoic center here, and the vessels are radiating away from it, kind of in a spoke wheel pattern. This was focal nodular hyperplasia. Kappa cells and bile ductules are both present, so nuclear medicine studies can be utilized to confirm the diagnosis. Kappa cells may be confirmed by a sulfur colloid study, that's about a third of the time, and bile duct cells can be visualized on a HIDA scan. Now to hepatic adenoma. Hepatic adenoma is a benign hepatic neoplasm containing hepatocytes, scattered Kappa cells, and no bile ducts. The absence of bile ducts makes a nuclear medicine HIDA scan a useful test to distinguish between FNH, which contains bile ducts and will be positive on HIDA, versus a hepatic adenoma, which does not contain bile ducts and will show a paucity of uptake on HIDA. Adenomas are much more common in females, especially with prolonged oral contraceptive use. When seen in males, adenoma may be associated with anabolic steroid use. Other associations include collagen vascular disease and type 1 glycogen storage disease, that's von Gierke's disease. There are 4 histologic subtypes with varied imaging findings. We have the inflammatory, that's the most common and has the highest bleeding risk. We have the HNF1 alpha mutated, that's the second most common, characterized by multiple adenomas, and this is associated with familial adenomatosis polyposis and von Gierke's. Then we have the beta-catenin mutated, that's the least common, and it's seen in men on anabolic steroids, and it has the highest risk of malignant transformation. And then we have the unclassified. Adenomas have a relatively high risk of hemorrhage, which is often the presenting symptom if it's not caught incidentally. For this reason, incidentally discovered adenomas more than 5 centimeters are usually resected because of their high risk of hemorrhage. The beta-catenin mutated subtype has the highest risk of malignant transformation. Adenomas are supplied by the hepatic artery and thus tend to be hypervascular on arterial phase. Some subtypes may demonstrate intralesional fat, that's the inflammatory subtype especially, which on MRI will demonstrate T1 hyperintensity and signal loss on out-of-phase images. Adenomas may be difficult to differentiate from other hypervascular liver lesions in the absence of fat or hemorrhage. As stated above, each subtype has slightly different imaging features, making confident imaging diagnosis somewhat difficult and often requiring tissue sampling for confirmation. Adenomas are typically circumscribed masses with arterial hyper-enhancement, becoming iso or hypo to liver on portal, venous, and delayed phase imaging. They may appear heterogeneous due to fat or hemorrhagic content, and a fibrous pseudocapsule may be present, which tends to enhance late. So on these images, we have first a coronal portal venous phase contrast enhanced CT, and it demonstrates a heterogeneously enhancing hypoattenuating mass in the liver, which is a non-specific appearance, by the way. Then on the in and out of phase MRI, we see a mass in the right lobe of the liver that demonstrates signal loss on the out of phase imaging consistent with a lesion containing intracellular fat. So this was likely the inflammatory subtype of a hepatic adenoma. There are no specific ultrasound features to distinguish an adenoma from other hepatic masses. An adenoma may be hyperechoic, isoechoic, or hypoechoic relative to normal liver. Nuclear medicine is also not usually helpful to differentiate adenoma from other liver masses. Adenomas are usually photopenic on technetium-99 metastable sulfur colloid scintigraphy, in contrast to focal nodular hyperplasia, which would pick up the tracer because of the presence of the hepatocytes and Kappa cells, but not always. There's usually lack of uptake on a HIDA scan, again due to the absence of biliary ductules. In addition to adenomas, other fat-containing lesions in the liver include lipoma, which is very rare, angiomyolipoma, and pseudolipoma of the Glissen's capsule. Biliary cyst adenoma is a benign cystic mass lined with biliary type epithelium. Although benign, most are surgically resected since malignant transformation to cyst adenocarcinoma may occur. These typically appear as a multiseptated cystic mass on all imaging modalities. Cyst adenoma and cyst adenocarcinoma are not easily differentiated on imaging. Mural nodules should be regarded with suspicion for malignant transformation to cyst adenocarcinoma. So this image shows us a well-defined, large, solitary unilocular cystic mass at the hepatic interlobar region with enhancing thin, smooth septi and a thin wall. Histopathology proved this to be a biliary cyst adenoma. Thank you very much for your attention. The next thing we'll talk about would be hepatic infection. I hope you found value from this discussion, and if you did, give it a like, share, comment, subscribe if you have not subscribed yet, and I will see you in the next one.